Dr. Lisa Jacobson. We will be speaking today about Attention Deficit Hyperactivity Disorder, or ADHD, and particularly with regard to understanding and diagnosing ADHD appropriately, as well as thinking about areas for assessment and intervention in this condition. Specifically, if we think about ADHD and we think about children or individuals that are often characterized as being disorganized, forgetful, inattentive, distractible, impatient or impulsive, or overactive and on the go, these are individuals who often come to the attention of teachers or parents or even medical providers due to the impact that these symptoms have on their daily functioning across the settings of their lives. So as an example, let me tell you about Joey. Joey is an 8-year-old little boy who was referred by his parents to their pediatrician due to concerns about his behavior and his school performance. So some of the difficulties reported were that Joey has trouble following directions at home and at school. Although he's a very smart little guy, homework takes a really long time and requires adult assistance. He is unable to do that independently. Completed homework then rarely gets turned in at school. He typically forgets at least one of the materials that he needs to bring home. He blurts out comments and interrupts others in conversation, which gives him some social difficulties. He has trouble staying in his seat, both at school and for eating dinner. He struggles to follow daily routines at home that require multiple steps, as he gets easily distracted by his toys or by television. His room is a mess. His book bag is a mess. His papers are often lost. He can be reactive and easily upset, particularly by the end of the day when he's eating dinner or he's at home with family. And all of these symptoms or descriptions probably sound familiar to individuals who parent or work with children like Joey, children who very well may have ADHD. So as an overview, we're going to be talking about children like Joey, children with ADHD or Attention Deficit Hyperactivity Disorder. We'll talk first about definitions and the diagnosis of the disorder, its prevalence or frequency in this country, and then comorbidities or other conditions which go along with ADHD and the related costs, and particularly treatment and intervention resources. So it's also important to think about, for ADHD, what it is and what it is not. So it's a diagnosis of both inclusion and exclusion. In other words, it's important to know what ADHD is not and what might contribute to it and make it worse, but those are not core symptoms, as well as what those core symptoms of ADHD are. So specifically, with regard to the Diagnostic or Statistical Manual of Mental Disorders, 5th edition, or DSM-5, this is a disorder that reflects a characteristic pattern of behavior and cognitive functioning. We'll describe that more in a moment. The disorder is present in multiple settings, not just in one place or one setting for the individual, and it results in social, educational, or work performance difficulties, which are known as impairment. Specifically, when we think about the symptoms of ADHD, the inattentive symptoms or symptoms of inattention reflect things such as failing to give close attention to details or making careless mistakes, difficulty with sustained attention, whether in play activities or work, difficulty listening, not following through on instructions or failing to finish things, difficulty organizing work or performance, a tendency to avoid tasks that take effort, tendency to lose things, become easily distracted, and be forgetful, either for materials or for events. And these 9 symptoms reflect the diagnostic criteria for inattention in the DSM-5. With regard to hyperactivity or impulsivity symptoms, there are also 9 symptoms. These are things such as fidgetiness or squirming in seat, leaving the seat in classrooms or other situations where remaining seated is expected, running about or climbing excessively, having difficulty playing quietly, being described as on the go or driven by a motor, this high level of motor restlessness, talking excessively, so verbal restlessness as well, blurting out or interrupting, and difficulty waiting. I have one of those symptoms is noted in red. That's the only change between the DSM-4 or the 4th edition and the current or DSM-5 edition. It is a simple wording change. There hasn't been any substantive changes to the diagnostic criteria as we've moved from the DSM-4 into the DSM-5. Specifically, consistent with the DSM-5 model, you can at this point diagnose ADHD as in partial remission, which would indicate that full criteria for the disorder was previously met, but presently the individual demonstrates fewer than full criteria over the past 6 months. But there is still evidence of impairment or difficulty in work or home or classroom settings. There's also the possibility of specifying the current severity. So mild, moderate, or severe, reflecting the number of symptoms in excess of those required for diagnosis that are present, and the amount of additional impairment that seems to be given by those symptoms. Specifically, as we look further, there are core features of the disorder that may not reflect entirely ADHD, and that's important to note. So specifically, as we just mentioned, inclusion criteria include the inattentive, forgetfulness, distractible, forgetful, and, sorry, I'm going to rephrase that. Inattention criteria include forgetfulness, distractibility, slow completion of tasks, or losing things. There also are the impulsive and hyperactive symptoms of overactivity, restlessness, fidgetiness. These are the inclusion criteria. And in order to have a diagnosis of ADHD, at least 6 symptoms of those lists previously presented of inattention, hyperactivity, impulsivity, or both types, the combined type of ADHD, must be evident. The criteria specify that some symptoms must be present prior to age 12 if this is an adolescent or adult that is presenting for the first time, and that symptoms should be evident across settings, and that they're not due to another mental or cognitive disorder. And that is important because we want to make sure that diagnosis is appropriate. As these core features are not exclusive to ADHD, and we'll talk about that in a moment, it's important to note that you can be clear on what symptoms the individual is demonstrating, but might not be sure about the etiology or where these symptoms are coming from, what's contributing, which can impact treatment effectiveness. Specifically, there have been a few changes as well to the DSM-5, not with regard to, the symptoms criteria that I mentioned, but with regard to the descriptions and the age of onset. So descriptions have been adjusted to make diagnosis in late adolescence or adulthood a little bit more straightforward and consistent across providers. So for example, the childhood item suggests that one of the criteria for hyperactivity or impulsivity is that the individual often runs about or climbs. In adolescents or adults, this might be limited to feeling restless, so you don't actually have to see an individual who's climbing on the desk at adolescence, but might simply be feeling restless. Again, for the motor restlessness item, on the go, acts as if driven by a motor, DSM-5 now specifies that in adults, this might reflect them feeling uncomfortable being still for an extended time, and might be experienced by others as restlessness or being difficult to keep up with in terms of their daily functioning. So some changes in wording to make it a little bit more consistent in terms of what we see across the lifespan. With regard to age of onset, the criteria for DSM-4, the previous version, indicated that symptoms that caused impairment were present before age 7. Retrospectively, it's very difficult for parents and individuals to report whether a symptom was present before 7 or after 7, but most people can agree before that symptoms were present during grade school or elementary school. So the new criteria suggests that several symptoms were present prior to age 12. And in terms of adult diagnosis, so diagnosis of individuals who are 17 and up per DSM-5, it is possible to make the diagnosis with only 5 rather than 6 symptoms of the disorder. Again, in terms of pervasiveness and impairment, these are criteria in DSM-5. Under the pervasiveness criterion, symptoms must be apparent in 2 or more settings, so at home and at school with friends or relatives, or in other activities. So there is a requirement that both parents of children and teachers of children report symptoms so that you are able to identify the pervasiveness of the symptoms. Additionally, with regard to impairment, DSM-5 specifies that there must be clear evidence that symptoms interfere with or reduce the quality of an individual's social, academic, or occupational functioning. So there needs to be a way in which we clearly identify how these symptoms are interfering with life activities. And these are things like an impairment rating scale or daily adaptive ratings by interview, by parent rating, by teacher rating that indicates the degree to which these behaviors are interrupting or impairing function across settings. Furthermore, in terms of pervasiveness, there is a specific criteria within the DSM-5 now that in order to make the diagnosis in school-aged individuals, so children and young adults, the diagnosis should include information obtained from parents and teachers. And there is a specific criteria that says confirmation of symptoms across settings really can't be done accurately without consulting informants who have seen the individual in those settings. So in other words, the report by a parent of what the teacher has said about the child may not be adequate. We may be required to obtain information directly from the teacher. And furthermore, examination of the individual, the client, the patient, in a clinician's office, so when a child is referred to a pediatrician, a psychologist, a counselor, that examination may or may not be informative because signs of ADHD may be less evident or absent when the child gets frequent rewards for behaving appropriately, is closely supervised, is in a novel or unfamiliar setting, is engaged in interesting activities, has consistent external input or stimulation, and is in a one-on-one situation. So in a clinician's office is not the same kind of situation as at home doing homework or in the classroom doing learning activities. And this is very clearly spelled out so that if the symptoms are not seen within the clinician's office but are reported as evident across settings otherwise, the diagnosis can still be made. As I mentioned, inattention and hyperactivity symptoms are not exclusive to ADHD. While they do reflect the symptoms of ADHD, it's important to recognize what ADHD is not. So individuals that have depression might show slowing, forgetfulness, inattention, distractibility. In young children with depression, it's not uncommon to see irritability and hyperactivity as well. So it's important to rule out that there are mood or anxiety or other affective disorders that may be accounting for some of these symptoms or the individual's presentation. It's important to note that there are certain illnesses or infections that can produce that sort of inattention, slow processing, or even irritability and hyperactivity in children. So it's very important, certainly, to think about other potential medical causes and rule those out initially. Certainly, you can have co-occurring situations where an individual had a traumatic brain injury or a TBI, and as a result has symptoms consistent with ADHD. But in other cases where it's less directly obvious to the casual observer or the parent or teacher, it will be important to rule out other medical causes. Specifically, there are sleep disturbances that may give rise to restlessness or poor attention, distractibility, poor concentration, difficulty sustaining attention. And in particular, obstructive sleep apnea has been associated with hyperactivity as well as learning difficulties. Certainly, situational reactions or stress, family moving, financial difficulty, lots of individuals living in the same home can certainly give rise to some of these behaviors which may be temporary in nature. As is consistent with DSM terminology, it's very important to rule out an intellectual disability or a cognitive reason for difficulty understanding and following directions. That would include things like a language disorder or a learning disability, and we'll talk further about a learning disability in a little bit. It's important to note that all of these listed conditions on this slide likely will not respond to the same interventions in the same way, which results in increased treatment cost, frustration of parent and child, and increased emotional cost. Important to think about what ADHD is. ADHD is a comprehensive disorder, and we'll speak about that. And neuropsychological evaluation can help clarify the picture. So this is a constellation of inattentive and or hyperactive impulsive behaviors as described. Commonly, these individuals may also demonstrate a pattern of slower cognitive processing, or what's called sluggish cognitive tempo, or SCT. This is more common in children with the inattentive only type of ADHD, but also can be misinterpreted as language or difficulty understanding, as children can simply be very slow to respond. Commonly, children with ADHD also show a pattern of some level of executive dysfunction or executive difficulty, and we'll talk about that more specifically, as well as a pattern of comorbidities or co-occurring conditions, which may further complicate treatment. But it's important to identify the co-occurring conditions, as these offer areas to target intervention and ways to best implement supports for the child and or family. In terms of thinking about assessment of ADHD, we have an executive function clinic where I work, and we think very carefully about taking history, which reflects what the parent or parents are reporting regarding development of symptoms, when they started, how a child has behaved consistently over time, what specific concerns have been noted. We pay attention to observations of behavior during testing, with the caveat that we understand we may not always see the behaviors to the same degree in a one-on-one quiet setting relative to home or classroom. But we also think carefully about standardized assessment of particular areas of functioning, such as intellectual functioning and language functioning, in order to rule out intellectual disability or a language disorder as the reason for the difficulties the child is having. We think about initiation and processing speed with an eye to this condition called sluggish cognitive tempo. We think about multiple aspects of attention, so not simply paying attention, but selective attention, sort of ruling out things that you don't need to focus on in order to pay attention very specifically to targets expected. This can be very sensitive to ADHD. We think about auditory and visual span tests. So what is the child's attention span within a structured, quiet setting where we can hopefully get the best estimate of how they can function? We think about sustained attention, or how a child independently can sustain attention to a task that is quite often tedious or boring in nature. We think about reaction time or vigilance in response to targets, how well someone can sustain their attention and then can modify that in response to a different amount of time that might come towards them. And then certainly divided or differential attention. Can you multitask? Can the individual pay attention to multiple pieces of information at the same time and use it effectively, as in a classroom when there are multiple things going on that the child or the adolescent might need to attend to? We think particularly about executive function, as I mentioned. Those skills that are important for academic and vocational success, so things like working memory or being able to hold information in mind, fluency or efficiency in mind, switching between tasks, disengaging attention in order to re-engage it on another aspect of the task, inhibition or being able to inhibit automatic responses or inhibit impulsive responses in order to focus more effectively on the task at hand, organization, and particularly with regard to organizing and planning a particular approach to a novel problem. These are aspects of executive function which are critical for all of us, but in particular to individuals with ADHD, as they can be easily disrupted by disruptions in attention. And finally, as mentioned, it's important to investigate or examine comorbidities or co-occurring skills, such as reading and math skills, mood symptoms, other aspects of behavior symptoms that may be a problem for the individual or maybe exacerbating symptoms of inattention or hyperactivity impulsivity. Let's speak for a minute about neurodevelopment. I think it's very important for individuals who are working or teaching individuals with ADHD to think carefully about the actual brain differences that we see in this condition. So this slide is taken from a paper from part of the NIH team, study of normal development, and what you see is a red arrow reflecting change over time. So these are compilations of scans of brain thickness in terms of age 5 all the way to age 20. So during essentially school age and most of college development, this gives you a sense of gray matter maturation or the cortical maturation pattern. And what's important to note is that red is immature or least mature gray matter, and purple You can see down on the right, there's that scale with pink at the top, pink and red at the top, and purple at the bottom, purple being most mature. What you can see is that there is a difference between, so there's a difference in terms of the degree of red or immature cortex from 5 all the way to 20. And what you certainly can see is that the pattern develops to a large extent from the back, or what's reflected here as K, to the front, or up here, where the arrow is. And you can certainly see that there's a little bit of a difference with greater maturity here on the left side than on the right side in this image. And even at 20, what I'd like to point out is that even by 20, there's not very much purple, in fact. You can see on the top image here, there's still immaturity in terms of some of the aspects of the prefrontal cortex that are really integrating and responsible for inhibitory control. In fact, down here, this red aspect, which is consistently still immature, is part of the orbital frontal cortex, which is really important for affective control, emotional stability, regulating impulsive reactions, particularly in emotionally salient or emotionally relevant kind of conditions. So you can see that although there's a lot of development that happens over time, certainly in a typical individual, by 20, the cortex has a lot of development remaining. This next slide shows you the pattern of development that is different between ADHD and typically developing individuals. So in this case, the numbers that you see reflect the age 7, 8, all the way up to 13. So during that sort of elementary to middle school age, what you see is that the darker reflecting color is areas in which it reflects differences, areas in which there are more than 2 years of a delay between children with ADHD and children with ADHD and typically developing controls. So what you can see is that as children age, there is a difference in terms of where the brains of children with ADHD reach maturity and when relative to typically developing peers. And in fact, there's quite a number of regions where typically developing controls are at least 2 years ahead of children with ADHD. The figure down on the lower left just shows you in terms of overall regions where the ADHD group showed delayed maturation in terms of attaining peak cortical thickness at least 2 years behind typically developing children. And the only region here, this right example, this pink reflects the area in which you see earlier cortical maturation in ADHD. That is generally the motor strip, so the hyperactivity is reflected there. Overall, taken together, I think what this slide and the previous slide indicate for us is that development of the brain in terms of thinking about cortical maturation or gray matter, it's a long process. It takes even more time than we think in terms of school and college functioning and early vocational entry. But there's also a delay when you think about the difference between children with ADHD and their typically developing peers. This next figure shows you that the pattern of development also is associated with outcomes for children. So what you see on the y-axis here is an example of cortical thickness. The measurement doesn't matter for our purpose today. The x-axis here is age. So again, this is 7 to 17-year-olds. And what you can see is that for controls, there's a slight decrease in thickness of cortex over time. What you can see in the blue circles and the green triangles, these are both cases of children with ADHD. The children with the green triangles are those for whom there is a worse outcome over time. So you can see that they start off with a very different cortical thickness relative to children who do not have ADHD or typically developing controls, and that there is a difference in terms of outcomes, so that the more atypical your brain development, the worse your outcome, even though over time, by the time these individuals are 15 to 17 years old, there's not a significant difference in terms of cortical thickness, but it really is a matter of pattern and developmental course rather than where you end up. But there's an association then for pattern of development and outcomes. This slide reflects just a simple comparison of sorry, let me take that arrow off. This slide reflects a simple comparison of boys versus girls, and it simply is designed to show that there's also a difference when we think about ADHD, there's also a difference when we think about children who are typically developing in terms of girls versus boys. So consistently on this slide, blue reflects the boys and red or pink reflects the girls. And you can see that in many cases, girls reach peak maturity. Here, for example, in the frontal gray matter right here, you can see that girls are quite a bit ahead by about 2 years in terms of their gray matter volume in frontal regions. Same thing here when we think about parietal gray matter. Girls are substantially ahead of boys in their development. That is also the case for white matter. There's a different developmental curve. Boys have more, but the curve is a little bit different. And overall, in terms of volume, boys tend to have larger brains than girls. But what's important down here in the bottom figures is really that there's a difference in terms of the maturation curve. Girls are, in fact, a little bit ahead in terms of reaching peak volume. This slide then shows you the difference between ADHD and typically developing peers. So in this case, the typically developing children are in green. Children with ADHD are shown in orange. And what you can see is that across regions, there is, in fact, a decrease in surface area for all the brain regions reflected here, so that there is a different course of development, and it results in less area, less gray matter for areas important for function, right frontal lobe, right temporal lobe, right parietal, even right occipital, where there's a little bit less difference over time. But in each case, the differences get a little bit less over time. The lines come closer and closer together, ultimately, when you think about where they end up versus where they began at age 8. Again, the take-home being that individuals with ADHD show a different course of development, less typical than their peers without ADHD. So overall, in terms of thinking about ADHD then, the summary is that these are children who show delayed development of self-regulation, so attention regulation, behavioral regulation, and this may be directly related to delayed maturation in key cortical or brain regions, as well as white matter tracts that support self-regulation. They show frequently deficits in key executive functions, such as inhibitory control, working memory, and planning, and these are certainly frequently accompanied by associated conditions that might share the same brain underlying findings. So frontal striatal and frontal cerebellostriatal frontal connections, or basically those connections coming from the frontal regions important for control to the basal ganglia, or regions that are important for regulation of affect or mood, as well as behavior and attention. So when we think about what causes ADHD, then, it's important to think about whether this is simply a frontal versus more of a whole brain presentation. So certainly, as I mentioned, there are impairments both in white matter circuitry connecting frontal regions, as well as differences in structural development. So the prefrontal cortex, or the frontal regions, are smaller. The cerebellum is often smaller, an area important for regulation and timing as well. And basal ganglia regions have been shown to be smaller, particularly in boys. There's altered functional connectivity, by which we mean changes in the way that the white matter connections seem to work within this disorder. So there's both less white matter, but it also seems to work differently and maybe not as effectively or as efficiently in this case. And there certainly is emerging evidence from medication studies suggesting that children with ADHD who are not medicated, who have never taken a stimulant or a non-stimulant medication, show smaller volumes in their gray and white matter in their brains relative to children with ADHD who have been well and appropriately medicated. So some beginning evidence that medication may help to normalize brain structure and potentially brain function. So let's talk now about epidemiology, or prevalence and frequency, and what co-occurs with ADHD. So specifically, ADHD prevalence estimates have ranged pretty broadly, and that certainly depends on where in the country and what kind of sample is being assessed. but ranges from 2 to 18% in community samples of school-age children. General current prevalence is about 11%. 1 million more children had a parent-reported ADHD diagnosis in 2007 compared to 2003. These are the most recent numbers from the Centers for Disease Control that have been published. And that reflects a 22% increase in 4 years, which is pretty substantial. And you can see the numbers here. Just over 4 million had a current diagnosis in 2007. 2.7 million of those were taking ADHD medications, so about a little over half were being medicated. And 5 million ever had a diagnosis of ADHD, so that's a lifetime prevalence. And certainly, even with the recent estimates from the CDC of autism, that certainly works out to be much more common than the prevalence of autism. Specifically, so this slide shows you then the percent of youth, again, school-aged youth, that were ever diagnosed with ADHD according to the most recent National Survey of Children's Health, which was done in 2011. So you can see here, this is where the number from 11% came from in terms of current prevalence across the country. But obviously, there's quite a bit of variation. And this figure shows you a map of the United States with color coding for prevalence. So I am in Maryland, so that's why I've had that highlighted. The Maryland rate is 11.9. The lowest or the least frequently, the state in which ADHD is least frequently diagnosed is Nevada. That's 5.6. And then Kentucky seems to have the highest rate at 18.7%. But you can see the variation. There's certainly variable practices and various diagnoses that happens across the country. This next figure shows you the treatment modality that's being offered. So the color coding of the state across the country reflects the parent's response of whether the individual had medication treatment over the past week of this particular survey that was done, with the dark blue states then having at least 80% reporting medication treatment for children diagnosed with ADHD, and the light being less than 70%. The size of the circle then reflects the percent of responders showing receiving behavioral therapy over the past year. So larger circles reflecting more likely to have received behavioral therapy, the smaller circles reflecting individuals less likely to have been, or fewer respondents suggesting they received behavioral therapy over the past year for their child with ADHD. And you can see that, unfortunately, there is quite a lot of variation, including states where there's a lot of reporting of medication treatment, such as Virginia, North Carolina, but very little report of behavioral therapy, as opposed to other states, such as Pennsylvania up here, for example, where you have relatively fewer reporting medication treatment, but relatively more reporting behavioral therapy. And overall, when you think about preschool children, the data suggests that less than 1 in 3 children, I'm sorry, I'm going to restate that. For school-age children, less than 1 in 3 children over age 6 received both meds and behavioral psychology intervention or behavioral therapy, which is considered the gold standard, the combination of treatments. Over only half of preschoolers, so children ages 4 to 5 with ADHD, received behavioral therapy, which is the recommended first-line treatment for this particular group. About half of preschoolers with ADHD were taking medication for ADHD, and about 1 in 4 were treated only with medication. So you can see a real disconnect in terms of what we know to be gold standard and how prescription and provider practices are playing out across our country. Another issue to think about with ADHD is heritability. So this is a highly genetic condition. And you can see that there are a variety of numbers here on the slide, but ultimately you can see parents, children, and siblings have an increased risk over typically developing individuals from families where there's not a family history of ADHD. Another thing that contributes to ADHD is age and expectations in development over time. So in particular, we know that older adolescents are less active, generally speaking, than 5-year-olds. So there's a change in presentation over time in terms of what individuals look like. This figure, this graph that you see down here in the bottom half of the slide, shows some very interesting data from Ben Leahy's work. This was published in 2005. He has done further work since then. But what you see here is on the y-axis, you see the percent of the group meeting criteria for a different subtype. And down here on the x-axis, you see the year or the wave of assessment. So individuals at their initial visit, at sort of time 0 here, were diagnosed as meeting a particular subtype, the inattentive subtype, the hyperactive impulsive subtype, or the combined. If we just look, for example, at the hyperactive impulsive subtype, these are these solid circles right here. What you see is that by 2 years after diagnosis, about 40% of those individuals are meeting criteria for a different subtype. By 8 years after that initial assessment, close to 100%, or 90-some percent, are meeting criteria for a different subtype. So one of the challenges for diagnosis is that individuals do not demonstrate the same subtype consistently over time. They are going to present differently. And this is most common, as is suggested by this figure, for those who are presenting with the hyperactive impulsive only subtype initially. They are less likely to be hyperactive by adolescence and more likely then to demonstrate inattention symptoms, bumping them more likely into that combined group. Another thing to think about is relative age, or age for grade. So we know that behavioral expectations change as children enter school. And one of the things that is most interesting to look at is the age relative to the school kindergarten entrance cutoff. So for example, if you look at states that have a September 1st cutoff, so children have to be 5 by August 30th in order to start kindergarten, the children most likely to be diagnosed with ADHD, that's the dark bars, or be prescribed medication, the gray bars, the highest rate is in children that have that August birthday. So they are the youngest children in the class. They're most likely to be diagnosed as ADHD because they are relatively immature for grade. The least likely individuals, generally speaking, are these September babies. So they're the oldest ones in the class. They have a birthday on September 2. They missed the cutoff for 1 year. They had to wait a whole year to go to kindergarten. You see the same pattern then again with states that have a December 1 cutoff. Again, the children most likely to be identified as ADHD and prescribed medication are those with a November birthday, so the ones who are very young for grade, whereas the least likely ones, or almost the least likely ones, are those, again, who had to wait an entire year to enter. And this is, again, has been demonstrated in other countries as well, that relative age for grade, relative maturity is critical when we think about these children. Let's move on and talk again about comorbidities and complexities. So what else is going on? What tends to accompany ADHD? One of the things that's important to think about is comorbidities. So co-occurring conditions can increase treatment resistance. So it's important to identify what else might be occurring, what else might be complicating the clinical picture in order to best target interventions. These are often other behavioral disorders, such as oppositional defiant, ODD, disruptive behavior, or conduct disorders, but they can also include anxiety, obsessive compulsive disorders, or OCD, motor disorders, such as tics or Tourette syndrome, and sometimes also autism spectrum disorders, or what used to be called pervasive developmental disorder, PDD. The combination of several disorders together, while common, can be much more resistant to treatment than ADHD alone. So it's important to identify these comorbidities as early as possible in order to identify effective interventions or treatments in order to make the individual as successful as possible to support their success. This figure shows you a visual of comorbidities. So more than 2/3 of individuals with ADHD have a comorbid diagnosis. Most commonly then, if you look at this figure, that reflects the learning disabilities, reading, math, written language disability. You also see a very high comorbidity in terms of the behavioral disorders, as mentioned, conduct, autism spectrum, depression, anxiety, etc. And what we know is that the risk for multiple diagnoses, i.e. more than 3 conditions, increases with poverty. Not surprisingly, there are certainly a number of stressors and family risk factors that happen that increase the likelihood that children may develop self-regulatory and learning difficulties, and then that certainly has its own set of additional complications. When we think about learning disabilities in particular, about 25 to 70%, again, a huge range depending on which study and where the children came from, of children with ADHD have math difficulties, and up to 82% of children with learning disabilities have ADHD. Again, the rate varies by subtype, with a little bit more difficulty likely in terms of math learning disability relative to reading learning disability, but again, substantially greater than the percentage in the regular or typical population. Children that have comorbid or co-occurring learning difficulties or disabilities and ADHD tend to show more severe attentional difficulties and weaker academic performance than children who just have learning disabilities alone. So that's really notable. And they also show weaker academic performance than children with ADHD alone. So you see sort of the converse, where the comorbid condition leads to much more difficulty paying attention and weaker academic functioning. This obviously has important implications for how individuals can function and what kind of support they will need in the classroom and beyond. With regard to executive dysfunction, ADHD has certainly been called a disorder of inhibitory control at core. This came from Russell Barkley, several of his works. But at core, when we think about even the criteria, the impulsivity criteria really are about disinhibition. You can think about the motor symptoms, an individual who is out of their seat, who is driven by a motor, who is fidgety. This is motor disinhibition. We see it in the verbal or the vocal symptoms as well. Children who are disinhibited or impulsive tend to make constant noises. That's a common complaint, that the child is humming to themselves, talking to themselves. They're just loud. They talk to themselves. They interrupt others. And socially, these difficulties can cause problems with social relationships in terms of the interrupting and being bossy, that sort of disinhibition, not knowing when to stop directing others' play. We see this inhibitory difficulty in attentional dysregulation as well. So the ability to sustain effort, to inhibit distractibility, to inhibit looking, getting up, going somewhere else in order to sustain focus or concentration. Holding multiple steps or a sequential process in working memory in order to perform a task requires inhibition of other behaviors. Avoiding distractions in order to selectively attend to particular tasks. These all are critical executive functions and components that we see disrupted in children with ADHD. Another thing that is particularly important to think about is the content or context interaction. And by this I mean, unfortunately, this slide actually has animation, but you can't see it. But what this demonstrates to us is that from first grade to ninth grade, the amount of learning, the amount of content expected from children obviously increases substantially. Not only the academic content, but also the expectations for independence, the expectations for managing your belongings and your materials, the expectations for managing your time and planning your activities. At the same time, we provide kindergartners and first graders with a lot of support to do those kinds of things. We prompt them, we remind them, we give them labeled cubbies, we give them school supply boxes, all kinds of things like this. Over time, just as children are being expected to do more and more things independently and presented with an awful lot of content, we fade out those supports very quickly so that the amount of contextual support is actually much less than for children who are expected to do lots more independently. Some children manage this just fine. Other children, particularly children with ADHD, and particularly those with ADHD and learning disabilities, they have a really difficult time with this. And you see patterns where, in fact, at 6th grade as they're moving into middle school, or at 9th grade when they're moving into high school, you see real difficulty, real patterns of they were doing okay, and now all of a sudden the child is lost and floundering and showing a decrease in performance. And in fact, there was a study not so long ago that was published by Joshua Langberg and colleagues looking at the way in which the transition into middle school is associated with changes in the reduction in ADHD-related symptomatology in youth with ADHD. So, for example, as I mentioned earlier, children with ADHD become less impulsive and hyperactive over time, generally speaking, although those behaviors are certainly still evident. That decrease over time was shown to be disrupted as children went into middle school. That clear developmental improvement became worse all of a sudden as children moved into middle school. So that change in supports or withdrawal of supports and increase in contextual and daily expectations for children actually was associated with an increase in ADHD symptomatology. When we think about ADHD and comorbidity as well, we think about academic skills and those components of academic skills that are domain general, by which I mean they're important for skills across domains. So we think about reading fluency in particular, but you can think of processing speed as certainly something that is relevant to multiple areas of function. And it's highly salient or highly relevant to ADHD because a commonly seen pattern is variability in processing speed in ADHD, just a pattern of occasional very slow responding or responses, slow and what we call lapsy attention, where somebody is on it, and then entirely lost, daydreaming. And that inconsistent or variable performance seems to be characteristic of ADHD. And this slowing or inefficiency can impede their reading fluency, which is certainly critical for comprehension. So being a slow processor or a slow reader or an inconsistent reader can create secondary attention problems in that it may take much longer to hold on to get to the end of a passage, in which case there's a lot more information to be held on to be remembered. It creates a bottleneck in the process and increases the demand for working memory or the ability to hold multiple steps, multiple pieces of information in mind and integrate them effectively so that by the time the individual gets to the end of a passage or a chapter, they're actually able to remember what it was that they read. Inference, take information away with them. And those processes implicate the cerebellum and the basal ganglia regions that have been implicated in ADHD and are highly interconnected with frontal regions such as prefrontal cortex, suggesting, again, delays in development or neurologic immaturity in terms of automaticity and efficiency of processing. Another area that we can see real difficulty in ADHD is language. And these difficulties can be subtle, but also can be quite variable. And it certainly depends upon the extent of comorbidities. So reading disorder or dyslexia certainly has its share of language-related weaknesses and difficulties. There are speech-language impairments, as I showed you in that figure, that can co-occur with ADHD. And certainly the communication deficits notable in autism spectrum disorders can certainly play a role in language deficits. However, even children with ADHD who don't have co-occurring reading or speech difficulties demonstrate a unique pattern of abnormalities in their language development. And by this slide represents an overview of what those deficits can be. So in children that have ADHD only, again, without additional comorbidities, you can see a pattern of a variety of skills that have been shown to be weaker in these children, and which seem to be associated with verbal working memory deficits and result in impairment on complex language-related tasks. We'll walk through this in more detail. When you think pragmatic communication difficulties, think about the DSM criteria for ADHD. So there are interpersonal social communication weaknesses that can be evident in ADHD. But generally speaking, these literally reflect the diagnostic criteria. So you see excessive or inappropriate output in social settings, such as interrupting, talking excessively, difficulty waiting their turn, not listening to others. So these are literally pragmatic social weaknesses, but reflect ADHD in particular. You also see difficulty attending to or reading social cues as evident in these children. And at the extreme, it can look a little bit consistent with an autism spectrum disorder. You can see symptoms that appear autistic-like, but are not certainly an autism spectrum disorder. So in these cases, children with ADHD are less likely to stop and attend to and therefore read verbal, nonverbal, and situational cues, and then, of course, less likely to respond appropriately. They're more likely to give tangential responses that may not make sense based upon what was said or what was asked. They tend to have more self-focused speech rather than speech that is focused on others, sort of purely reflective of a concern or a thought about what's going on with another person. They have difficulty maintaining conversational turns, again, because they tend to be more focused on what they're thinking of. And they tend to be less likely to consider the needs of the listener in conversation. So again, these can lead to difficulties in social communication. When we think about inhibitory deficits in terms of language, you can also see that their difficulty inhibiting makes them more talkative, both with others and out loud, as I mentioned. They make more vocal noises and are apt to blurt things out. They tend to disrupt conversations of others. They don't always attend to social cues and therefore inhibit their own impulsive responses or language. And they're apt to forget rules for behavior, that you're supposed to raise your hand and wait your turn and wait until others have stopped before talking. So they are more apt to have difficulties with these things, which reflect, again, at core, the inhibitory deficits characteristic of children with ADHD. Furthermore, you see difficulties in terms of restricted output in on-demand settings. So when a child is asked to respond to a specific question or asked, what did you do today? Or what were the reasons for this particular conflict in terms of a history class? You see less output. They're less able to communicate key information to others, whether that's on request or whether that's in a cooperative task. They produce less information on request, and they have greater organizational difficulty in terms of pulling the information together and producing it in a way that makes sense and is cohesive, which then affects their recall and retention of information, their ability to produce. We also see a pattern of difficulties in recall and retelling of semantic information, so stories, in which case data have suggested that children with ADHD perform more poorly than controls on those kinds of tasks. They have organizational difficulties that are evident in use of more ambiguous references, so he or they rather than a specific use of a character name or a specific person, inappropriate word substitution so that it's not entirely clear what they're referring to, and limited use of strategies for organizing new or novel information. So these kinds of organizational weaknesses give them a poorer pattern of performance in terms of recalling and retelling meaningful information. As a result, not surprisingly then, you can see a pattern of memory vulnerabilities. So they rapidly forget verbal information. They have more memory difficulty when there's a greater quantity of information to be recalled. The information to be recalled is more complex or many more details. The length of delay increases, so if you ask them right away, they might be able to do it. If you wait a day, they may no longer remember. When recognition cues are not present, so they're more likely to have difficulty in an open-ended, tell me what you know about this topic versus, answer a multiple choice or a yes, no, was this the case in the story that you read? And they're more likely to have greater difficulty remembering information when it requires organizational strategies from them, as just mentioned. One of the things we also see in ADHD that produces, that is related to their language difficulty is difficulty with internalization of speech. So in children, as they develop, Vygotsky has shown and has described a developmental shift from audible or talking out loud about what you're doing to internal speech or a subvocal, silent, self-directed dialogue. When you're going to the grocery store and you're talking to yourself in your head about what you thought was on your list, you are using this internal speech, assuming that you're not saying out loud, I need to get milk, don't forget the milk. This internalization of speech that children develop over time and should be there by the time children are in elementary school supports their self-directed organizational speech. So this use of speech for self-regulation of behavior. Wait your turn, don't blurt it out, don't forget to raise your hand. These prompts that children say inside of their heads to help regulate their behavior. These form a foundation for other higher level cognitive functions, such as working memory and planning. And they're anticipatory to planning and execution of tasks. So you're using this kind of internal dialogue to help plan and perform more complex things. And so it forms the foundation for self-inhibition and ultimately inhibitory control. Barkley suggests that these skills then are not developing in the same way in children with ADHD, so that verbal working memory can be thought of as an internalized language used to talk with yourself to provide reflection, description, instruction, and questioning, which in turn facilitate problem solving, development of rules and understanding of rules, and reasoning in terms of complex reasoning. ADHD disrupts the development of internalization of speech because it disrupts the inhibition that's needed to support this internalized speech. Without it, then, the individual fails to develop an appreciation for rule-governed behavior, and without this, lacks self-regulation. That's broadly speaking. But generally speaking, what you see is that weaknesses in verbal working memory, at core, potentially this weakness in internalized language used for self-regulation, results in difficulties regulating mood or affect, motivation, arousal, or attention, and gives rise to difficulty with reflection and application of strategy and problem solving. So this idea that you have to inhibit other behaviors in order to activate your working memory is something that is a particular area of weakness in youth with ADHD. Again, verbal working memory is critical for maintaining and manipulating information in use. It's essential for more complex language-based tasks when you think about reading comprehension, how well you're pulling all the information together and making an inference from it, or assigning motives to characters based upon multiple aspects of behavior. For written language production, being able to come up with ideas, put them in an appropriate sequence, hold them in mind while you write them all out, type or write. It functions together with lexical retrieval speed or rapid naming or efficient retrieval, and can produce what's called a dual deficit in ADHD, where slower and more variable responding puts an increased load on the ability to hold information or working memory, but if there's a weakness in working memory, then children have both problems. They're slow and they have less ability to hold information online while they catch up, and gives you difficulties with problem solving, planning, and considering consequences. When you think about strategy and problem solving then, we see a clear pattern in the literature of children with ADHD having greater difficulty than controls, using feedback to adjust their behavior. So when they're solving a problem, they typically fail to hold information in mind regarding the success or failure of previous responses. So this cause and effect or appreciation for consequences is related to weaknesses in verbal working memory. They typically have difficulty using information then to influence or inhibit future behavior. So they're not tending to use the information they've learned, they're not holding it, and therefore they're not using it in order to inform their next behavior or next response. And potentially, again, this is related to less common use or less frequent use of self-regulatory verbalizations, whether that's out loud or internal. And therefore, then you see difficulties restricting behavior in response to specific rules or cues or instructions, because they're not holding those rules or cues or instructions in mind in order to perform a strategy or solve a problem. Again, when you think about interpersonal or social difficulties, you see difficulties with self-regulation and self-direction of social and interpersonal behavior, related to weaknesses self-monitoring their behavior and their own performance, weaknesses making inferences in terms of reading tasks and oral discourse or oral conversation. They're less likely to notice and monitor inconsistencies in the information provided. They're apt to be distracted by extraneous details and therefore miss the main ideas in reading or social context. They're less likely to monitor their own comprehension in an ongoing way. And when they do notice difficulties in comprehension, they are then less able to apply appropriate strategies to remediate comprehension failure. So not able to say, okay, wait, I didn't understand that, I didn't get that, I should go back and reread, or I need to figure out what was the main idea. So as a result, they're more apt to struggle to make and adjust plans for accomplishing a goal, to come up with what's the purpose of reading this, what's the main idea, what do I need to do with this information. So you see that difficulty in terms of monitoring strategy as well throughout. Overall in ADHD, these appear primarily related to the executive and working memory deficits rather than a deficit in basic or core language understanding, vocabulary knowledge, for example. As we think about beyond school, ADHD beyond school, and sort of what that looks like over time, some have suggested that ADHD symptoms tend to change with age, such that up to 80% of children grow out of ADHD in adulthood. And while I did show you data suggesting that children's symptoms do change over time, in fact, it may be simply that the symptoms don't go away, but they may change in terms of the way that they appear. So hyperactivity, as acknowledged in the DSM-5 may not be climbing or running at inappropriate times in adulthood, but may be restlessness and an inability to be patient and to remain focused. This physical impulsivity may morph into verbal impulsivity, saying the wrong thing or speaking out of turn. Childhood inattention or difficulty completing schoolwork can then, in adulthood, look like difficulty completing work tasks on time, meeting deadlines, difficulties remaining concentrated or focused on one task at a time. You may find individuals that constantly are doing lots of different things and aren't actually able to finish any one thing appropriately. So the symptoms don't actually seem to disappear, but they simply change over time into a different presentation. As a result, ADHD is associated with significant costs over time. There's academic, social, physical, vocational, and globally economic costs for the country as a whole. So with regard to academic difficulty, children with ADHD, individuals with ADHD, are more often, as we mentioned, to have co-occurring learning difficulties that are both separable, i.e. a language-based or a math learning disability, and intrinsic to ADHD, so related again to the weaker working memory, the weaker comprehension. They're more likely to have less education ultimately, have lower educational attainment, to be retained in grade or have more academic failure, to have more suspensions, particularly in high school, and they're less likely, therefore, to complete high school. When we think about social functioning or peer interactions, children with ADHD have been reported to have up to 3 times as many peer problems as typical peers, and 10 times more likely to have difficulties that interfere with their friendships in a substantive way, so resulting in fewer friends or more difficulty keeping friends, more problem behaviors related to social situations, and poorer psychosocial adjustment. In girls, is more apt to include internalizing kinds of concerns, and then overall resulting in higher rates of alcoholism, substance abuse, depression, in adulthood. Sorry, for some reason this slide came out a little weird. In terms of physical injury rates, so there are costs as well along these lines, where children with ADHD or individuals with ADHD are apt to have more both non-fatal and major injuries, more inpatient, outpatient, and emergency department visits or admissions, substantially so, and greater risk of involvement in things such as motor vehicle crashes, drinking and driving, and traffic violations. So again, when you think about impulsive behaviors or overactive or less attention to cause and effect and consequences, that can result in actual physical injury. And overall, this resulted in an estimated 7 million ambulatory care visits for ADHD in 2006. With regard to financial difficulty, this is certainly a real issue for adults or young adults that are moving into the workforce. So adults or young adults with ADHD are less likely to have a savings account. They're more likely to have trouble saving money for bills then, and therefore more likely to owe money to others. This is a real difficulty for individuals with ADHD. Economic costs beyond the individual, things you might not think of. So using a prevalence rate of 5%, which is a little bit lower than the current incidence, using an annual cost of illness, this calculation, this is estimated between $36 to $52 billion annually in 2005 dollars. And I looked and couldn't find any more recent updates here in terms of these numbers. But using the 2005 dollars, this is estimated between $12,000 and $17,000 annually per individual. The total cost for ADHD in the United States was close to $32 billion, including treatment of patients, other healthcare costs of individuals with ADHD, healthcare costs of family members that may be stressed by ADHD, and work loss costs of adults with ADHD and adult family members who have to leave work to pick up their misbehaving child. Also, when you think about productivity, you think about ADHD and lost days of productivity. So overall, across 10 countries, a study looked at approximately 143.8 million lost days of productivity a year attributed directly to ADHD and not due to co-occurring conditions. Partly this was due to the fact that workers with ADHD are more likely to have at least one sick day relative to non-ADHD peers. They perform more poorly at their job, and they're more likely to be laid off as well. So this is a really serious outcome when you think about the productivity impacts on countries as a whole. So let's think about treatment. What can be done as a result? This is a slide that just simply shows you some of the things that are out there in terms of ideas, everything from sort of things that have been tried that have been debunked, brain gym, Ritalin O's, I don't recommend them, but certainly other medications that have been tried, stimulants and non-stimulants. What really works? If you think about it, the MTA, or Multimodal Treatment Study, has demonstrated for us a number of important facts. There were this was a randomized clinical trial of youth with ADHD. There were 4 conditions, and it's important to note that there was an active medication management condition with stimulant medication that was very carefully titrated up, particularly carefully in order to ensure optimal dosage. Then there was a systematic and comprehensive behavioral treatment arm. There was a combination arm, which included both this careful and active medication management with stimulants and the systematic comprehensive behavioral treatment arm. And there was a community comparison group where treatment was done as usual following a comprehensive assessment that ensured, yes, in fact, these individuals did meet criteria for ADHD. Of those, 68% were treated with medications, but at a much less intensive level relative to the medication condition in the study. So visits were about every 6 months. There was not necessarily organized after-school dosing, and there was no formal school contact made in terms of assessing effectiveness. Taken all together, these data suggest that all 4 groups showed reductions in symptoms over time, but children in the combined treatment and medication management group showed significantly greater improvement than those in the community care group. So what we found is that combined treatment proved superior to intensive behavioral treatment and or community care, while the medication management only did not. More specifically, what we know is that although the initial published results favored optimal medication management for symptom reduction only, it depended on the outcome measure and depended on the symptom presentation and the comorbidities. So the combined treatment was found to be superior when examining composite outcomes: social functioning, adaptive skills, and symptom reduction. And outcomes for comorbid ADHD and anxiety was particularly improved with combined treatment. Take-home being that complex disorders require comprehensive intervention. The more comorbid the condition, the more likely that the individual is going to need the combination of behavioral and medication support. When we think about classroom interventions, most importantly, it's going to be critical for individuals working with children with ADHD to provide environmental scaffolding for the executive dysfunction. So thinking very carefully about what kinds of supports does the individual need in order to ensure that they are in fact paying attention, that they can hold the information, that they're not given multiple directions or multi-step tasks too quickly in order for them to, so quickly that they are not able to keep up. There's also some suggestion that adjusting the presentation of information, providing some variability within the context of structure may be supportive. So, for example, not simply calling on every child in a classroom in the same order so that children can zone out when they're done being called on, but where they're not entirely sure and you create a culture of a little bit of uncertainty where they might be called on at any moment, may be more likely to maintain attention within reason. A classroom that is still structured and consistent as well is critical. Considering, as we mentioned, with the changes between elementary to middle and high school, considering the context, the level of demand, the level of independence, the level of self-management required of students, and providing supports at critical points such as entry into middle school, entry into high school, and beyond for some children that may need additional support longer than most typically developing children. And then thinking about the combination of emotional and academic climate to supporting learning. So providing an emotionally supportive learning setting is just as important as providing excellent academic instruction. And this might reflect intentional individualized support, both for self-regulation as well as for academic skills, identifying and addressing co-occurring learning disabilities or comorbidities, and social skill training with specific support for generalizing that to situations where the skills are required. This is simply a little cartoon suggesting that potentially we just should arrange our libraries in order of attention span. So individuals who have a very short attention span can be directed to the right place. A few other resources that are more likely to be effective. So the National Resource Center on ADHD is a program of CHAD, or the Children and Adults with Attention Deficit Disorders, and that website is helpforadhd.org. This is a site where there are lots of different resources about treatment, about diagnosis, about different kinds of interventions, but generally speaking, very empirically solid information that I often recommend to families. Another resource is the Center for Children and Families, which was at University of Buffalo, is now at, State University of New York at Buffalo, is now down in Florida. But this provides literally clickable resources for documentation about ADHD in both English and Spanish, treatment information about psychosocial or medication treatment, and then behavioral resources such as creating a daily report card at home. There are lots of other resources on this site, but the one nice thing is that they are literally things that you can click and hand out. You can read as a parent, you can hand out to parents as a clinician, you can hand to teachers. This is the Center for Children and Families now at FIU, so similar resources available on this website as well. This is the CHAD website itself, where there's information, again, specifically for parents, adults, young adults with ADHD, individuals working with them, and things like support groups and other resources as well. The parentsmedguide.org site actually is a very comprehensive and well put together resource relating to information that families might want to know about stimulant or non-stimulant treatment. Very clearly talks about side effects, talks about therapeutic effects, provides information about both ADHD and some co-occurring or potentially unrelated affective disorders such as depression and bipolar. They also are available translated into Spanish so that that's available for a wider audience, but certainly also a very good and empirically sound support. And then finally, many states have adopted the Common Core in terms of curriculum standards for both math standards and the English language arts standards. And one of the things that I think families and individuals working with children with ADHD ought to familiarize themselves with is what is expected in school at different ages, what the standards are, given the high prevalence of academic difficulty in youth with ADHD. So these standards they're in the entire age range from kindergarten through high school. And what you can see if you click on, for example, the math standard, you can choose a grade level, you can choose a topic, and then it will show you what the specific goals are or the specific content aims for children, what exactly the objective is that they are expected to document, to meet as they're going through school. And you can see all the way through the grade levels in terms of what's expected under which math domain, and the same is true for reading. But again, this allows parents and individuals working with students with ADHD who aren't necessarily teachers themselves to have a good idea of what the child is expected to do so that you can specifically provide support for both core academic skills and also for application of information. Under the English and language arts standards, you can see what is required in terms of reading comprehension, et cetera. So in terms of taken together then, these are a variety of resources that hopefully will be helpful in addition to consultation with pediatricians or with child psychiatrists or with psychologists or neuropsychologists in terms of assessing and providing support for these children. For attending, for their attention to this information, and hope that this has been helpful. Refer you to your local providers or your local university and the Technical Assistance Center in terms of providing further information and follow-up in this area. Again, thank you very much for your attention and for your attendance. Thank you.